So, good morning. Today we'll be discussing a atypical presentation of bilateral OSSN. So, let's have an overview of excuse me, it's not moving ahead. Okay, yeah. So, anhidrotic ectodermal dysplasia, it's a congenital disorder affecting the X chromosome, the EDA gene, ectodermal dysplastic gene on the X chromosome, and it's an X-linked recessive disorder, which mainly affects the ectodermal components, that is the hair, that is hair loss, anhidrosis, that is loss of sweating, and teeth involvement. Characteristically, it does not involve the nails, the salivary glands, or the palms and soles as seen in palmoplantar keratoderma. So we had a young patient walk into our OPD, a 14-year-old, complaining of bilateral reddish mass on the temporal conjunctiva. As we can see in the picture, there is almost symmetrical looking elevated lobulated mass with sentinel vessels, internal vascularity. In the right eye, it was involving around 8 clockas of the limbus. In the left eye, it was involving around 6 clockas of the limbus. External examination of the patient showed shiny hair with a receding hairline, loss of sweating on the face, abnormal teeth, and a familial history showed similar complaints of ectodermal dysplasia in the younger brother, but not in the youngest sister, which suggested the X-linked recessive pattern. However, none of the parents or any cousins, first or second degree relatives were involved. Examination of the patient showed good best corrected visual acuity 6/6 with significant against the rule astigmatism. Movements were full and free. The patient had severe dry eye with 5 and 4 millimeters on Schirmer's test. Now the lesion was evaluated first using ASOCT, which showed abrupt transition with hyperreflective epithelium. Characteristic scleral cleft was present as shown by the green arrow, which suggested a carcinoma in situ with sparing of the sclera. And these findings were seen bilaterally, suggestive of a neoplastic etiology. A reverse impression cytology was done at our center, which showed increased nuclear to cytoplasmic ratio with atypia, nucleoli, and this was suggestive of a bilateral OSSN carcinoma in situ. Now our first challenge was whether to go for a surgery in a bilateral case with severe dry eye or go with a conservative management. So we went ahead with a topical immunotherapy, that was interferon alpha 2B drops, 1 million international units 4 times a day. At 4 weeks, there was no change in the size of lesion. Why? This was our first challenge. So in retrospect, when we reviewed the literature, the disorder EDA gene typically acts by the immune pathway NF-kB, and the immunotherapy interferon also activates the same pathway to have the antineoplastic effects. So the mutation actually did not allow the interferon to work, and hence our immunotherapy failed. So our challenge ahead was, should we go ahead with a topical chemo or now start surgery? And since he had a very severe dry eye disease, there was a high risk of keratomalacia. So under hourly lubrication, we went ahead with low dose topical mitomycin C 4 times, 1 week on, 1 week off. At 6 cycles, at the end of 6 cycles, we had a very significant response with regression in the height of the lesion and also the limbal clockas. Now, after 6 cycles, the patient had started developing punctate staining with mitomycin, so we went ahead with a surgery. Our surgical challenges here were we would not be able to do an allograft of conjunctival autograft from the other eye because it was a bilateral tumor. So we went ahead with a white margin excision, epithelectomy, cryo, and amniotic membrane with BCL with regular 3-day follow-up. And finally, we did manage the dry eye with hourly lubrication, preservative-free. We could salvage around 6 clockas of limbus in both the eyes, and the vision was salvaged. The histopath was as shown. We can see that the basement membrane is intact at all points, but there are neoplastic cells in clusters and forming the squamous keratin pearls, suggestive of an OSSN. Finally, at 9 months, this is the patient. He has a healthy limbus, healthy surface, and he has a Y6, that is 20/20 vision, preserved vision, and the astigmatism has also significantly come down. So, thank you. This is the first reported case, so in the literatures we don't have any other studies or case reports to discuss. Thank you.
Any question?
How would you manage in this case limbal stem cell deficiency after doing this surgery?
Sir, actually, we had counseled the patient that there may be a requirement for alloslet in the post-op period. At 9 months, still we have a healthy surface, and we have not gone ahead with a limbal. We could salvage around 6 cloacas of limbus in both the eyes following surgery. So right now we are just observing the patient because the younger brother also has a similar condition. So taking an alloslet from the brother would may cause a problem in the brother. So right now it's a wait and watch game. In case there is no recurrence, we can maybe at 2 years follow-up, we can plan an alloslat from the parents.
Very rare case, Dr. Shalin. What does the literature say? Is this the first reported literature? And what is the difference with other features, like in case of xeroderma pigmentosa? And how do you expect that recurrence rate will be there?
So actually, the margins were clear, the base was clear, and there's no, I mean, the ASOCT till now, it doesn't show any epithelial changes any longer. So we are not expecting a recurrence, but these are very unpredictable cases. I mean, they can have a second primary as well because it's an immunodeficiency state. So I think it's just a wait and watch game right now with monthly follow-ups and regular screening of the ocular surface and regular screening of the siblings as well because there's a chance of malignancy in them.
One last question. How are you going to follow up with that sibling is he have also got a similar lesion, or you want to follow up in?
So the sibling, the younger brother, has severe dry eye, but he doesn't have any conjunctival lesion as such. This patient was actually, his first follow-up somewhere else was noted as Herbert's Spitz, and he was treated accordingly. So right now that's the only changes we are looking for in the younger sibling, and both of them are on follow-up, regular follow-up every monthly.
Okay, thank you.
Thank you, sir.
Just one more question. Apart from OSSN, any other systemic neoplasia known to be present in ectodermal dysplasia syndrome?
No, sir. The anhidrotic ectodermal dysplasia, the ocular manifestation described are nasolacrimal duct obstruction, punctal agenesis, and sometimes entropion, congenital entropion. Okay. But OSSNs or any other conjunctival intraocular neoplasms are not yet described in the literature. Okay.